Hello, everyone, and welcome to today's webinar, a virtual symposium, Down Syndrome, Aging and Health. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer speaker system by default. If you'd prefer to join over the telephone, just select phone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to the presenters by typing your questions into the questions pane of the control panel on the right-hand side of your screen. You may send in your questions at any time during the presentation, and we will address them at the end. Would now like to introduce Shannon McCormick.
Good morning. My name is Shannon McCormick. I'm the Executive Director of the Down Syndrome Association of Connecticut. I'd like to welcome everyone. Thank you for taking time from your busy schedules to join us today. And I'd also like to thank the Connecticut Council on Developmental Disabilities for providing funding support for this event. For those of you who may not be familiar with our organization, I wanted to take a moment just to give you some information. Our acronym, DS-ACT, is 2 words with emphasis on the word ACT, and that was chosen very deliberately to reflect our long history. It's almost 37 years now of acting and advocating on behalf of people with Down syndrome, their families, and the people who support them in Connecticut. We will drop a link into the chat to our website so you can check out some of our programming. But really, when people ask me what we do, I like to summarize by saying we make connections. We connect people to resources, we connect them to supports, and we connect them to each other. It can be very confusing and lonely and difficult to live with a disability. One of the antidotes to that is a strongly connected community. So that's where our focus is. As our keynote speaker, Dr. Chicoine, I'm sure will tell you, our understanding of Down syndrome is changing very rapidly. As an example, my son is 24, he has Down syndrome. When he was born, his life expectancy, they told us to expect through his mid-40s, so not very long. And honestly, planning for his retirement was not on the list of things to do. They sent home with us from the hospital. Yet here we are. The vast majority of people living with Down syndrome today can expect to live into their 60s and 70s. The potential to live a very rich, long, fulfilling life if you have Down syndrome has never been greater, but we are also in uncharted territory. You know, service systems, sometimes they work, sometimes for a variety of reasons they don't, or the different systems don't talk to each other. There are lots of little things that often need to be adjusted to make things work smoothly. You take that system issue, the rapidly changing understanding, and then layer in on top the very personal kinds of nuanced responses people need sometimes when they have Down syndrome. And it can mean that all of us, caregivers and service providers alike, really have their hands full. So we started this project a year ago to try to reduce that load that everyone is carrying. Our goal is to share information, current information about Down syndrome and aging today, and also to start a conversation among all the different players in this and all the different supporters to understand what's working in Connecticut right now, what isn't, and how we can work together to make things better, to improve healthcare access for people with Down syndrome, particularly for adults and adults who are aging in ways that we had not anticipated even a couple of decades ago. So in the coming months, we will be launching a companion website that should have resources and some forms of support for people who are tackling healthcare issues in the adult part of the lifespan. We are hoping that this webinar, this conversation, and that website will be the start of the creation of a roadmap for us. You know, when you're on vacation, you need to have, or at least I do, I'm a planner, so I need to to have a roadmap. I need to know what things I need to pack to take on my trip. I need to know what everybody in my family needs to pack. I need to know what we're going to do. I have to have plans for fun, plans for rest, plans for how to get from, that long day from one point to the other. I need to know all of that stuff. And I am hoping that this effort will be the beginning of that for our families in Connecticut. With that, I would like to introduce our project coordinator, Diane Bilyak, and she will give us some details about how this all started from her perspective. Diane.
Thank you, Shannon. So hello, everyone. I'm going to provide a bit of personal history on why this grant and why now. My sister, Christine, has Down syndrome. She's 57 years old. And for the last 20 years, she's referred to herself as Dr. Irma King. She told everyone she'd become a physician because of the colleges she stayed at as a participant at the Special Olympics. The Special Olympics was a big part of her life, and she was able to find success as a swimmer for almost 50 years because Connecticut provided other supports and funding throughout her development. Not enough for a medical degree, but enough, hold on a second, to have her live independently from her family, which she was itching to do since she was 5 years old. Over a year ago, that all grinded to a halt. Suddenly, there were no rungs left to use, and she reached a ceiling. This symposium is about beginning to cut a hole in that ceiling and mutually build new rungs for people aging with Down syndrome. For my sister and many like her, her former life unraveled during the COVID-19 lockdown. She was so shell-shocked throughout it. It was 18 months before she could return to work. After 2 months of being at work, she fell on the work van. At the time, she was okay, but after 6 days of her house manager and the local ER doctors ignoring our requests for more conclusive x-rays, pain management, and rest, when they finally agreed to give Chris a CAT scan, it was revealed that 2 fractures in her right knee, and she'd been walking on that for 6 days. The broken bones meant Chris had to go to a rehab center. Most of the staff there wouldn't provide accommodations for her specific needs, and she endured substandard personal care because of this. There was a wonderful social worker, hospitalist. We learned a lot about what hospitals and rehab centers have, but we didn't know any of this at the time. It kind of happened slowly. But Chris was determined to improve and return home. She wheeled herself around the hallways and was standing on her own, taking a few steps and transitioning from her wheelchair to a toilet, a chair, a car, and the bed. But when she was placed in a respite home for a month to learn how to walk better and manage her stairs, after about 10 days, she started to give up. Though no one explicitly told Chris her agency refused to take her back, she began to realize she wasn't going to her former home, and a condition known as transfer trauma set in, alongside her physical ailments, including hypertonic legs. From a psychological and emotional perspective, any of her normal reactions to her pain or confusion or fears were now treated as behaviors. Her symptoms from UTIs, food contamination related to celiac disease, and staff not changing her hearing aid batteries would give some nurses, CNAs, doctors, and support staff permission to devalue her experiences, further confounding her reality and confusion. As the transfer trauma progressed, she failed her yearly dementia test at her visit to the Adler Center at Yale, which is a geriatric center that also tests folks with Down syndrome for dementia. Now dementia became the alpha and omega of explanations, and many of our solutions to manage her trauma were not implemented. We were told basically to let Chris go and give up, but I couldn't do that. So over several months, I found a PT who was 100% committed to her job. Christine's diet was changed, and she started a blended day program with a direct care person to keep Chris active and engaged. Slowly, Chris began to transform back into a familiar version of herself. She does have dementia. That won't change, but it seems to have stabilized for now. Because I also attributed her situation to professionals not knowing much about Down syndrome, it appeared that ableism, intentional or not, was a factor behind this lack. I felt something needed to be done so others didn't suffer the same fate. So last fall, I approached Walt Glom from the DD Council just to kind of chat with him about, possibilities. And then Shannon McCormick from DS Act about writing a grant to educate professionals and caregivers, reduce silos, and encourage cooperation among separate groups working toward the same goal. I'm so grateful to the DD Council for accepting the proposal and to Shannon at DS Act for taking on this project. Though many days I felt despairing and hopeless, research and studies are pointing to improvements, some that I've read about and some that my optimistic sister has exemplified. This symposium is just the beginning of the changes to come in Connecticut for people with Down syndrome, and I'm looking forward to what the panel and Dr. Chicoine's talk will inspire in all of us. Thank you. Oh, and there's a picture of my sister, like a year apart. The first one is when she sort of came home. You can see how distressed she is. I don't really like to show pictures like that, but this is how she is now, and she's really happy, and she still has bad days, and but all that hard work and advocacy and help from other people and stick-to-itiveness has just kind of brought her back, and now we can really look at what all of her different symptoms are and how they're impacting her without the trauma part being such a big factor. So anyway, I'm happy to see the changes in her. Thanks.
There we go. Thank you, Diane. I am delighted to introduce our keynote speaker, Dr. Brian Chicoine. Dr. Chicoine is the medical director of the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois. He is on the faculty of the Family Medicine Residency at Advocate Lutheran General Hospital. He received his medical degree from Loyola University of Chicago's Stritch School of Medicine and completed his family medicine residency at Lutheran General Hospital. In 1992, Dr. Chicoine co-founded the Adult Down Syndrome Center, which has served and documented the health and psychosocial needs of over 6,000 adolescents and adults with Down syndrome since its inception. Dr. Chicoine has provided medical care for adults with intellectual disabilities for over 30 years and has presented and written extensively on caring for adults with Down syndrome. Please welcome Dr. Chicoine.
Thank you very much, Shannon. Can you see my screen? Yep. You can see it? Oh, interesting.
Yes.
I can't. Okay. All right. So thank you very much. I appreciate the opportunity to be here. I'm going to talk a little bit about aging and Down syndrome, and then I really look forward to hearing the panel and talk about some of the ways to address some of these needs. I often have said that innovation is wonderful, but without implementation, we're missing a key next step. And certainly, I'm eager to hear how you guys are looking to implement improving the healthcare for people with intellectual disabilities, specifically Down syndrome. And certainly advocacy is a big piece of that. And so I eagerly wait to hear your thoughts on those topics. As was mentioned, I'm the medical director of the Advocate Medical Group Adult Down Syndrome Center. We're in Park Ridge. We see adolescents and adults with Down syndrome starting at age 12 and use a team approach. In addition to medical care, we serve people in Illinois. In addition to medical care, we have 3 family physicians who work here, as well as we provide physical and mental health care here at the clinic, but also in the hospital, residential facilities, and we do have one nursing home we go to for some of our older folks who have either need for rehab or long-term care based on other health problems. And in addition to medical care, we have an occupational therapist who works with, and who also has a PhD in disability studies and who works with our individuals to try to improve their function. And then we have a licensed clinical social worker who helps address the mental health issues. I like to think of it as a 3-legged stool: physical health, mental health, and then functional health. And hopefully the team we have put together is able to provide that. And then the other component of that is our parent or patient advocates. Actually, our second one is just about to start. And they provide additional information to families, as well as help them negotiate or navigate the state system to get additional services, which is challenging. I talk to the staff regularly about, trying to help people navigate the healthcare system is part of our job, because it's not always easy for any of us, but certainly not for those with intellectual disabilities. We also provide education. We have a number of groups that in the last 2 years plus have been primarily virtual, but are starting to get going again in person, with social skills, health education, music group, and then give a lot of webinars such as today, as well as other presentations and other events. Again, really looking at, particularly around the issues of social skills, we feel that that's really does end up, when people don't have those skills, ends up leading to both mental and physical health problems, and hopefully addressing some of those issues up front can help prevent some of the downstream problems that some of our folks experience. So just as a disclaimer, this is educational purposes, certainly not intended to be a substitute for care with your healthcare provider or qualified professional. So again, we're going to my focus, again, I certainly can't address this whole topic in half an hour, but my topic is to address some typical aging in adults with Down syndrome, share some strategies to promote healthy aging, and hopefully those might be some things to work on as part of your advocacy, and then discuss ways to support aging in adults with Down syndrome. Again, hopefully things that I'm eager to hear how you're working on those things. So as was mentioned, I believe it was Diane mentioned her son or daughter being 24 and the life expectancy that they were told when he or she were born. We see that certainly that now there are more adults with Down syndrome living than ever before, and you can see from this information from a recent study that demonstrates that there's probably over 200,000 people with Down syndrome living in the United States, and roughly about 120, maybe 130, roughly people with Down syndrome over age 20 live in the United States at this time. So you can see that that's gone up significantly from 1950, being around 50,000. So a significant increase in the last few generations. And not only are there more people with Down syndrome living in adulthood, they're certainly living longer. So I had a great uncle with Down syndrome that was born in 1907. They didn't call that at the time, but his life expectancy was 9. And although he actually lived to be almost 40, the family history is not available, but very unlikely that he had congenital heart disease, because that certainly was a big factor in life expectancy in the past. When I graduated from medical school in 1984, the life expectancy of people with Down syndrome was only 28. And today it's about 60. And so really just a dramatic change. I don't take credit for it, but I don't think there are too many healthcare providers in the United States whose patient population more than doubled their life expectancy during the course of their career. Couple big issues there. One is the ability to treat congenital heart disease. 40 to 60% of kids with Down syndrome are born with some sort of heart defect, and the ability to surgically correct those really was not available. Certainly not into the late 70s, even the early 80s. And at one point they were available to other kids, but not kids with Down syndrome. So that availability has made a huge difference. And then I think moving people out of large facilities has also been a huge factor. And because as part of that, providing additional services, allowing people opportunities to work and to have recreation and exercise and other things that are much more part of the life of people with Down syndrome today, that have been so critical in not only life expectancy, but the enjoyment of life and the quality of life as well. So let's talk a little bit about aging. So what are some of the things that we anticipate when we talk about aging with the patients we serve and their families? One thing is we do see a premature aging in people with Down syndrome, and you see that not only in the onset of some health conditions that occur at a younger age in people with Down syndrome than in others. But we also see that people with Down syndrome, as they start to get beyond their mid-30s or so, they do seem to, their aging process does seem to accelerate. And then we also see then an increased rate of aging. And then also some of the other things with aging is that there's going to be some life changes, as just would be with any of us. So we see both some real advantages and some wonderful things, but also some challenges sometimes with when our patients become an aunt or uncle, which is obviously a common thing. When there's time to consider retirement and what are the implications of that, and what are the challenges of that, and what are the opportunities in retirement. With moving, particularly when it's associated with losing a family member, a parent passes away or a sibling passes away, and not only is there the grief of that situation, there's also then the need to potentially to move to a different setting, and what are those stresses. So all those things can play an important role in aging, as well as the stresses of aging, but also give us lots of opportunities to address those things. One of the interesting things during the pandemic, for example, certainly that, in March of 2020, the routines of many of us, and certainly people with Down syndrome, changed in a flash. There was sudden shutdown, and people weren't able to go to things. And a lot of our patients we see struggled with that. But some of our patients actually really flourished. They developed new ways to address their day, new ways to address their health. Developed what we call the groove, which is the tendency towards repetition or sameness that many people with Down syndrome have. And so, that they really were able to what I call have groovier grooves, where they really were able to function better, and we saw some people lose weight, and we saw some people sleep better, and have a lot of other things that they really did take advantage of those changes and promote healthier changes. The downside sometimes is as people do age, the grooves will change. Sometimes people will have less of a tendency towards following their routines and patterns as they age, and sometimes they actually become more sort of stuck in their grooves. And so there are some things that we need to address as people get older and anticipate those. So certainly when looking at promoting healthy aging, we really do look at look at it in the sense of as the World Health Organization, when really looking at physical health, mental health, and social health all being very intertwined. And this is not only true for health problems, it's true in health promotion. So really, as we promote one, we really anticipate we are promoting the others. And so we really want to not just focus on one, but focus on all of them. And certainly, and when we're addressing health problems, we want to look at all of them as well. So they can all be very intertwined. I think that this is clearly, not I think, this is clearly true for all of us. But I think this is even more of an issue for people with Down syndrome than others, because for a number of reasons, but one of them being communication. And so where a person with Down syndrome might find it challenging to express their concern of their physical health, and so sometimes it'll be displayed in a change in their mental health or their social health. So really trying to sort through those things as throughout the life of people with Down syndrome, particularly as they age and additional health issues become problematic. So how do we encourage health promotion? So really, again, not unique to people with Down syndrome, and you're not unique to aging, but things we want to continue to consider. Again, as Diane mentioned, some of the physical therapy issues that she did promoted with her sister. Those are things we want to think about, and not just accept early aging is going to be, there's nothing we can do about it, for example, or when someone gets dementia, there's nothing we can, nothing we can do about it. So lots of things we want to do to continue to, again, you think of that three-legged stool, look at the physical health, the mental health, but also the functional health. What can we do to try to help people function better, as well as have a higher quality of life, even if there are some health issues that they're dealing with. So really looking at sleep, healthy eating, exercise and physical activity, stress management, and then employment, recreation, and social opportunities, all of which are likely to change as people get older. A common thing with people with Down syndrome is that many will kind of consider them as children throughout their entire life. And I hear people say, well, how are those kids you take care of? And well, some of them are in their 50s and 60s and 70s. I certainly don't think of them as kids anymore. And so really, taking them out of that kids box, and the component of that is that people change over time. People say, well, he doesn't like to play basketball anymore. Well, he's 45 years old and he's, older and he's got some arthritis. Yes, he might want to do something different. So not wanting to play basketball is not a problem. It is just an opportunity to look for other ways to help him to promote his health. So good sleep is a very important thing, and I'll kind of run through these because I could spend hours just talking about these issues. But I think the key message here is that there's a lot of things we can do, even as people with Down syndrome age, to continue to promote their health and optimize their mental, physical, and social health. We talk a lot about sleep hygiene in our practice. How can we develop a routine before bed? How can we take advantage of that tendency of people with Down syndrome to have routines and to use routines? So let's use that to our advantage and to their advantage to have good sleep hygiene. Let's develop a schedule. Many of our people with Down syndrome do better with visual learning rather than auditory learning. So let's use visuals to assist them into developing these good, healthy routines. And again, I talked about this groove, this tendency towards doing things repetitiously. A lot of people with Down syndrome, once we teach them, some healthy habits, they will really stick with it, even probably more than the rest of us, as long as we're promoting that and we can get them into that good groove, if you will. If someone's having poor sleep, just like the rest of us, I teach in the family medicine residency program, and I'm constantly harping on the residents, is this something we're doing to the patient? Meaning, is there a medication we've prescribed potentially that can interrupt their sleep? Is there something else going on? Is there some other health issue that impacts on the sleep? We just don't want to accept that that's not, something that we can't do anything about. Consider natural products like melatonin, which we've had some good success with. And then in some situations, we have to look at prescription medications. The other thing is sleep apnea is significantly more common in people with Down syndrome. That's always something to consider when sleep is problematic. Healthy eating, there's certainly data done in folks without Down syndrome that healthy eating, can contribute to improved mood and certainly general feeling of well-being. So really addressing those, and particularly as people get older, I'm convinced that many people with Down syndrome go through life at least mildly dehydrated. A lot of our folks just don't have the same thirst mechanism. So making sure that people are drinking well. We know that that's a problem as people get older and can impact their health and their cognition and their ability to function, just being a little dehydrated. So really focusing on hydration, making sure people are getting good balanced meals, particularly as people get older, and sometimes they will not have the same hunger that someone else might have, or they had when they were younger. And so really making sure that people are getting balanced meals is so important. Looking at healthy portion sizes, limiting processed foods and pop and soda, and doing small changes over time can really help promote people's health and not not make some of these changes inevitable or without our opportunity to have some impact on them. Again, we have a lot of information on our website about ways that we promote these healthy concepts. And then exercise and physical activity, is so important. And so many, particularly in the pandemic, many people did not have as ready access to some of these activities. And we know that it has such an impact on not only physical health, but mental health. And really there's, from a standpoint of, we're gonna talk about Alzheimer's disease in a second here, clearly Alzheimer's disease, exercise is something that people are really looking at and what the impact on actually either preventing or delaying Alzheimer's disease is. And so exercise is so important. Find out what works for the individual. What does the individual like? Make it fun and social. Pretty unlikely that one of our patients is going to go downstairs into the basement or wherever the exercise equipment is and exercise while the rest of the family is sitting upstairs watching, TV and eating ice cream. I mean, it's just not likely to happen. So participate and make it fun and social. Incorporate it throughout the day. Just the usual park a little further away and those kinds of things to really promote activity throughout the day. And then there's certainly in the non-Down syndrome population, in the general population, there's information that exercising outdoors may have additional benefits. Do the same exercise indoors or outdoors, there may be some additional benefits to doing outdoors. So get outside and take a walk, go to the forest or the woods or whatever, and get outside and be active. And there's lots of we have lots of on our website. There's lots of information available on promoting exercise in people with Down syndrome or other intellectual disabilities. Stress management is so important. It's interesting, very few people with Down syndrome have high blood pressure, have hypertension. And oftentimes someone will say, well, that's because they don't have any stress in their life. And that's clearly not true. I like to say that stress is in the eye of the beholder. And so, not too many of our patients are responsible for paying the mortgage. And so that maybe not be a stress in their life. But just because I don't find what they find stressful, and what they don't find stressful, what I find stressful, doesn't mean that, doesn't negate either one of our, assessment of our own stress. So again, stress is in the eye of the beholder. People with Down syndrome have stress in their life. In fact, we have on the pictures you're seeing there, in the one in the lower left corner, Cindy, who's on the right there in the blue shirt, in our video on stress, we asked her about stress, and she gave a great description of stress. If you have an opportunity to take a look at it, I really encourage you to take a look. It's very interesting. Be aware that people with Down syndrome have what we call empathy radar. They can be very sensitive to the feelings of others, and so that can be a real positive thing if things are going well around them. But if things are not going well, if there's stress in the family, that can really affect people with Down syndrome. Oftentimes I hear, families will say, grandma's sick and she's dying, but we haven't told Joe or whoever our patient is with Down syndrome. And I say, pretty likely that Joe has some sense of that just by picking up on your emotions. And that's very true. We see that a lot in individuals with Down syndrome. So being aware that they're likely having this stress in their life and trying to help them address that. Provide in the moment support when possible. It's like the child you put in the snowsuit and you do all that effort, and then the child says, I need to go to the bathroom, and so you got to do it in the moment. You got to go back and take all and address it right then, even though it's inconvenient. That's the same thing with people with Down syndrome with stress. We got to help them, when they're expressing that, to say, okay, we're going to have an appointment on next Tuesday at 3 o'clock may be helpful, but addressing that in the moment, if at all possible, is also very helpful. And then work with a mental health provider. And that can be a lot of things, music therapy, art therapy. We have a lot of folks that do therapy through horseback riding and other things that really do seem to benefit them. So there's a wide variety of ways that can be addressed. And again, exercise. You're going to get tired of me hearing about that, I'm sure. And then looking at employment, recreation, and social opportunities. And I think the main thing, two things with this. One is that, people's interest changes with age, and that's not surprising. I mean, and so do the rest of us. And so that's certainly something to look at. Has the person, does the person have a very physical job that, when they were 20 was great, but now that they're 40 or 45, 50, that's really beyond their physical capabilities, and we ought to look at something different. And then the other thing, particularly with the pandemic, it's interesting. We found really as much challenge getting people back into activities as it was when they left activities at the beginning of the pandemic. And so people have kind of gotten used to being at home, and that's their new routine. And so what I call safe reintroduction. So kind of helping them back into step by step. And if we try to go too fast, too quickly, too far too quickly, a lot of people will kind of shut down. And so really trying to help what I call safe reintroduction into these opportunities is very important. And that's true whether there's, through the pandemic, through a physical health problem, mental health problem, helping people get back. And so again, that third leg, the functional leg of healthcare. Then I'm just going to real quick talk about some health conditions and a little bit about the prevention, treatment, and management. Lots of health conditions, unfortunately, more common in people with Down syndrome. And this is the list on the left there is really a rather short list, unfortunately. Lots of health issues that are more common. And actually, there are some issues, some health problems that are less common. Solid tumors, for example, breast cancer, colon cancer, high blood pressure, as I mentioned, atherosclerosis. We don't see very many heart attacks in people with Down syndrome. And type 2 diabetes, despite obesity being more common, type 2 diabetes seems to be less common. Unfortunately, one of the things that is more common, and particularly around the issue of aging, is Alzheimer's disease. And as you know, this is a progressive neurological condition that affects the brain. It's a type of dementia. Microscopically, when you look at the brain of a person with Alzheimer's disease, you see what are called plaques and tangles. And these are the microscopic changes in the brain that are consistent with Alzheimer's disease. They're often sometimes also referred to as neuropathological changes. And estimates vary on how frequently people with Down syndrome develop Alzheimer's disease, but some data suggest that as high as 55% of those in between ages 50 and 59, and perhaps as greater than 75% in those age 60 and older. And then the age of diagnosis is commonly around the age of mid-50s is commonly when people with Down syndrome are diagnosed with Alzheimer's disease, unfortunately. So, why is Down syndrome? Well, let me come back to that. So how do we make the diagnosis of Alzheimer's disease? So first, I want to look for the symptoms and a pattern of decline. And that's very important to rule out other causes. And so just as was mentioned, I think Diane mentioned with her sister with regards to having developed dementia, but there was a lot of other things going on there as well at the same time. And so addressing those other issues, physical therapy and whatnot, it really made a big difference. So whether these other underlying conditions explain the whole thing or whether explain part of it, we really want to address those to optimize the function of the individual as well as possible and as long as possible. So some of the things that are more common in people with Down syndrome that can cause dementia include B12 deficiency, depression, sleep apnea, hypothyroidism, cataracts. All these things can mimic or look like Alzheimer's disease, and we want to make sure these are being addressed. And when we went to that long list, many of those conditions on that long list, again, which is only part of the list, can contribute to the loss of skills, and we want to make sure we're addressing. So in the Global Down Syndrome Foundation, a group of us working with Global put together some medical care guidelines, and they were published a couple of years ago. So the recommendation that was that for adults with Down syndrome younger than age 40, be very cautious when diagnosing age-related Alzheimer's type dementia, because functional Alzheimer's disease or clinical Alzheimer's disease or symptomatic Alzheimer's disease is uncommon before the age of 40 in people with Down syndrome. But certainly as people, before the age of 40 in people with Down syndrome, but as people get older, and we really want to start to look and do some screening. And one tool is the National Task Group Early Detection Screen for Dementia that's available online. Very nice document, about 6 or 7 pages that you can kind of keep track of at home and share with your provider. So those are some ways as far as diagnosing it. I should just mention that the reason that Down syndrome, Alzheimer's disease, more common people with Down syndrome seems to be around what's called the APP gene, which is on the 21st chromosome. So it's thought that this higher expression of this gene contributes to the onset of Alzheimer's disease. So at least that's the running theory at this point. So what about how do we support people with Down syndrome? And I think from an advocacy standpoint, some of these things would be very important, and how we're looking to change, not just at the bedside, but what can we do beyond the bedside to support those trying to do the support day in and day out. So really, we like to really look and focus on what people still enjoy, particularly when they develop Alzheimer's disease. What do they still enjoy? What are they still capable of? Let's focus on what they can rather than what they can't do. At the nursing home, where a number of our folks with Alzheimer's go, they play a lot of bingo, and I see that frequently they actually respond very favorably to that, and I call that the bingo pace, where they were living before, the pace was more rapid, and that was a struggle for them because that was beyond their skills at this point. So slowing it down and getting at their pace, not doing nothing, but doing something that's at their pace is very beneficial. Using common good communication skills with regards to helping people be able to hear and helping not confuse people with background noise and things like that. Addressing sensory issues. Are there issues that they're having that make the environment challenging for them, and how can we address those things? And some of it may be vision, some of it may be hearing. And then are there other safety equipment or adaptive equipment that we can provide in the home or where the person is living to, again, to optimize their function. And as was discussed before, Diane, looking at what role does physical therapy potentially have to help, or occupational therapy, to help people function better as long as possible, whether they have Alzheimer's disease or just some decline due to aging. Really want to look for how do we help them find a medical home, and how do we help them get the care that they need when people get in the hospital. How can we provide information to the providers that are caring for them in the hospital? There's something called health passports, where it's kind of a description of the individual's strengths and challenges, and that's something that's very helpful to go along with the person to the hospital, so those interacting with them in the hospital can help not only understand where they typically function, but ways that actually we can help them get back to that level of function or beyond, potentially. Having someone stay with the individual while they're in the hospital is really very, very helpful. I made rounds this morning, and having families there that know the individual and can share the concerns and can provide information is very, very helpful. Personalize it. A lot of people caring for people in the hospital may not know people with Down syndrome, and so how do we get them to how do we get them to know a person with Down syndrome? Just pictures of the family with the person with Down syndrome. So simple things like that sometimes can really help to highlight that this is an individual that has skills and has enjoyed life and is not just a a sick person with Down syndrome that's sort of the sum total of the approach to the individual. So really kind of looking at the person as a whole person, and how do we try to get them back to that. And then, certainly families and others sharing resources with providers. A lot of providers don't have a lot of people with Down syndrome in their practice. And so sharing resources with them and helping be part of the team, if you will, the healthcare team, it can be very important. It would be lovely if families didn't need to do this, but I think the reality is that this is part and parcel to the need. So I'm going to stop. I think we do have a lot of resources if people want to take a look at those.
Thank you, Dr. Chicoine. That was wonderful. And I do have to say, when I get phone calls from parents, part of what initiated this project, in addition to Diane's experience, is when I get calls from parents, one of the places I look is your research page. So it is definitely a wealth of information. I'd like to take a moment here to introduce our panel moderator, Siobhan Morgan. Public service, the words public service define her in many ways. Following a long career in state government, working with persons with disabilities, Siobhan now works as a part-time advocate for Disability Rights Connecticut. She holds a bachelor's degree from Southern Connecticut State University and a master's degree in gerontology from the University of St. Joseph in West Hartford. She is an advisor for People First Connecticut, an active steward of the Little Free Libraries in Meriden, and a member of the charity club that serves the Meriden community. Her passion for aging and Down syndrome started 30 years ago with a woman named Sylvia who developed dementia at the age of 60. Siobhan, welcome, and if you would get our panel going.
Good morning, everybody. For some reason, my camera is not turning on. I don't know if it's just the power of the internet this morning or what, but I am here. So, oh, there we go. It's popping back up on my end. So, good morning, and I'm honored to be here with you all. And I'm gonna I get the honor of introducing our esteemed panel this morning. And first, I would like to introduce a former colleague of mine, Dr. Valencia Bagby-Young. And Dr. Val is a licensed psychologist and advanced practice registered nurse with certifications as a family nurse practitioner and psychiatric mental health nurse practitioner. She is the Director of Health and Clinical Services for the Connecticut Department of Developmental Services, known as DDS. And Dr. Bagby-Young provides statewide collaborative nursing and health oversight through departmental health standards, policies, procedures to advocate for routine, preventative, medical, and nursing care, and eliminate disparities in health care for individuals with intellectual and developmental disabilities. And the next person, okay. The next person I'm going to introduce is Daniel B. And Daniel is a regional long-term care ombudsman from the Department of Aging and Disability Services and has years of experience providing assistance with individuals in the aging and disability communities. Daniel received his master's degree in social work in 2016 with a focus on elders and families from Southern Connecticut State University, and as a Connecticut home care program care manager for the agency on South Central Area Agency on Aging. He is helping individuals transition back into the community after being institutionalized. For the last 3 years, he's worked as a regional long-term care ombudsman to provide the quality of life and care for Connecticut citizens residing in nursing homes, residential care homes, and assisted living communities. And Diane, who you've already heard from, is a writer and disability rights advocate. She is following in her mother Nancy's footsteps, who became a champion for equity and inclusion in 1969 when her daughter Christine was diagnosed with Down syndrome. In 2021, Wesleyan University Press published Diane's memoir, Nothing Special, The Mostly True, Sometimes Funny Tales of Two Sisters. A 2006 graduate of Yale Divinity School, she is currently serving as co-chair of the DSCCC's Disability Caucus. Diane will be sharing a personal account of some of the recent experiences she and her sister have endured that sparked the creation of this grant. And I'm also going to introduce Ashley Farnham. And Ashley is a program coordinator at the Community Vocational Services Incorporated, a private nonprofit organization supporting individuals with intellectual and developmental disabilities in the southeastern Connecticut region. Ashley is also a sibling to an individual with Down syndrome who has been a Special Olympics aquatics coach for over 15 years. And last but not least, Dr. Pixie Plummer is a primary care physician new to Bloomfield, Connecticut, with Starling Physicians. She is trained in internal medicine and pediatrics and completed a fellowship in neurodevelopment disabilities at Boston Children's Hospital in 2007. She has previously practiced at Bay State Hospital in Springfield, Mass, and in her home state at the University of Iowa. Dr. Plummer is committed to improving access to quality primary care for adults with developmental disabilities and complex special healthcare needs. Her career focus includes support for patients and their families and having a voice in how to make things better in healthcare and in our community. As you can tell, we've got a very highly esteemed panel, and I'm sure we've got a lot of questions from the audience, but I have a few to get us started. So first of all, I want to thank you, Doctor, for an incredible presentation. And I know from working in Connecticut for the last 30 plus years that there's probably a lot of case managers and supervisors and staff and family members on from the state of Connecticut, and I know that they appreciate the information that you shared. One of the things that I think that is really important, what you talked about, was the life expectancy and the importance of healthcare. And I was wondering if you could expand on that a little bit more about how important the routine healthcare, and I think that's something that it came up in your bio as well, Val. And am I jumping ahead, Shannon, doing the questions now? Do you want me to have people do their presentations?
Why don't we hold the questions and until after everybody's had a minute?
Okay, so we'll start with Dr. Val then. You're up, Val.
Sorry, I was trying to unmute myself. Okay. I do want to make one correction as a panelist. I am incorrectly listed as a medical doctor. My doctorate is in psychology, as Siobhan stated. I'm a licensed psychologist and psychiatric mental health and family nurse practitioner. My role and responsibilities as Director of Health and Clinical Services for the Department of Developmental Services involves general healthcare oversight for individuals with intellectual and developmental disabilities who are served by the department, and qualified providers or private agencies that are supported by DDS. This includes supporting individuals who live in residential homes, intermediate care facilities, those who live independently in their communities, as well as those who live with family members. In this position, I collaborate with statewide DDS nurse managers and nurses representing private providers to develop and revise standards of nursing and healthcare. Nursing care generally refers to those levels of support and care provided by licensed nurses, whereas healthcare references medical, dental, physical, occupational therapy, speech pathology, and other clinical services. DDS does have a separate division for mental health or psychiatric or psychology services, and there is overlap between psychology services and nursing as well. We provide support through health standards, policies, procedures, and as well as directly meeting with individuals and their families to provide support and advocate for them. The majority of our services are geared to persons with intellectual developmental disabilities, not specifically those persons with Down syndrome. However, I will highlight certain policies and procedures and educational opportunities that DDS offers that are specific to the healthcare needs of persons with Down syndrome. In 2009, DDS established routine preventative care guidelines. These are standards that are based on health and dental services, and they're based on the United States Preventative Task Force services recommendations for all people. They include screenings for changes in vision, hearing, diabetes, cancers, vaccinations, and other preventable diseases. The policy specifically references baseline echocardiograms for persons with Down syndrome if there's no previous record of cardiac functioning. So when an individual goes to see their primary care provider, the nurse develops a plan or a set of questions as a part of the physical exam that the primary care provider should be addressing. And one of those includes cardiac concerns or gastrointestinal concerns or other concerns that may be unique to people with Down syndrome. And it is imperative that those concerns are addressed either by the primary care provider or cardiologist, or there's been some baseline process for ruling out medical conditions and identified areas that may be unique to persons with Down syndrome. We also support dental care and services by having a DDS dental coordinator who is involved in assisting individuals and their families with receiving routine dental care as well as restorative care. Individuals with Down syndrome are noted to have numerous dental concerns that may be unique to them, and they include malocclusions, which are imperfections of the teeth that that are most noticeable when the person's jaws are closed and they present problems. There are congenital missing teeth, delayed eruption of teeth. The teeth may be smaller in size and may have very short root tips, which leads to early onset of periodontitis. The DDS dental coordinator provides oral hygiene trainings for staff and individuals. She meets families and individuals at dental appointments and helps coordinate services. For persons with Down syndrome, she emphasizes to staff and family members, as well as the individuals, the importance of good oral hygiene because the root tips may be short and have extra accumulation of oral plaque, which can lead to early tooth decay. The use of small toothbrushes is generally encouraged for persons with Down syndrome who have these dental concerns. DDS provides internships for dental students and dental hygiene students. Our dental coordinator organizes the internships, and she provides lectures, which she reviews with specific dental issues that may be related to persons with Down syndrome and ways to improve their oral health. At the onset of the COVID-19 pandemic, DDS met with the Connecticut Hospital Association to establish policies by which individuals with intellectual disability could be accompanied by a family member or a staff person. This was a time when hospitals were saying that no one could accompany individuals. So we worked to advocate for this, and it was very successful. So we recognized that there was a need to meet the needs of individuals that were served by a department. We developed health standards that provide a level of care that meets specific healthcare needs. For example, we have health standards related to safe eating and swallowing, food consistencies, osteoporosis, fall prevention, the use of homeopathic remedies, and health standards are available on our website. We have some separate nursing and health memos that are not health standards, but they address specific concerns. And this information is shared with DDS nurses as well as statewide private nurses. A specific impact for persons with Down syndrome is recognizing the need to address anatomical or physical features that may be different, such as a short neck or a shorter neck. And this may result in compromised breathing or a blocked airway. So this is important to know when there are positional changes, when a person is sleeping, when there may be a need for an emergency physical restraint or other activities that may compromise a person's breathing based on physical features. We support their mental health as well. Their social emotional needs are met by psychology services. We offer group therapies, therapeutic social groups, and other individual therapy and therapies that are based in the community. We have worked very hard not to limit our services or isolate individuals who are served by the department, but to make those services as accessible in the community as they are to other people. We recognize as people with Down syndrome age, they may have developed anxiety or obsessive compulsive disorders or behavioral concerns. And sometimes those concerns may be related to other conditions such as dementia. So we try to address those things and make sure that nurses are working in collaboration with our Division of Psychology and Psychology Services so we can meet the needs of the individuals to the best of our ability. Additionally, DDS has a legally required statute that where oversight of do not resuscitate orders is required. There is a review process. So persons who are served by the department who don't live in their own homes with family, or persons who are adjudicated, they have a guardian or a legal representative. There is a process by which, in order to change their code status, we would need letters submitted by physicians or advanced nurse practitioners who are caring for them, at least two, in certain specialty areas that provide a rationale for the change in condition. And it cannot be based on their diagnosis of Down syndrome or intellectual disability. It must be a medical condition that is terminal, is chronic and irreversible, and results in a poor prognosis. And those are reviewed. We have gone several years ago, we went to all of the area hospitals in Connecticut and the different regions and emphasized this legislative review process to make sure they were aware of it, because there were concerns that healthcare providers were advocating for a change in code status to do not resuscitate solely based on that the person had a diagnosis of Down syndrome or some other intellectual disability. So it was an opportunity to educate healthcare providers. During the pandemic, that legislation has not changed. It stayed in place. We advocate for people to receive the same medical care as other people. This includes organ transplants, and other health care that may be, people might assume someone with Down syndrome or another intellectual disability, it doesn't warrant that. We emphasize a quality of life, and we try to support individuals. We try to support them to live out their lives in their own homes, wherever that may be. So when somebody has a change in code status or they are experiencing a decline, we advocate for supports to be provided in their home. We try to avoid placing them at a skilled nursing facility or outside of their home, someplace which may cause more confusion and contribute to a more rapid decline. DDS has a mortality review process, which is a peer review to look at and develop standards of care so that we can ensure the health and safety of all persons served by the department. That's just an overview. It was quick, so I apologize, but just to give you an idea of what we do to advocate for all persons with intellectual developmental disabilities, as well as those with Down syndrome. Thank you.
Thank you, Val. And we already have some questions, so based on your presentation, thank you so much. Ashley, if you would like to do your presentation.
Well, thank you. Good morning. Welcome, everyone. So as Siobhan said, my name is Ashley Farnham. I'm a program coordinator for Community Vocational Services Incorporated, or CVS Inc. I've been there for almost 12 years now, serving individuals in the Southeastern Connecticut region in day and residential services. Aside from that, I'm also a sibling of someone with Down syndrome. So he is 24 now. And I experienced a lot of the same things that were already previously discussed, even though there's an 11-year age gap between my brother and I. So I was a little older to understand what was happening, but not truly understand what was happening. So he was definitely diagnosed really early on without telling us. And that was a really hard piece for my mother and I to really deal with. Sorry. And it really turned into us not wanting to keep him. He wasn't given much past 6. He wasn't going to walk or talk. And now he's 24, runs with Special Olympics, doing tennis and golf, and is a morning personality on a radio station. So he is now Wolfman Zach with WBLQ in Westerly, which is his dream. And I'm happy that he's there. So some of the struggles that we've dealt with going forward, even though he's 24, is like Dr. Val had said, dealing with DDS as a private provider, have had to do all of those trainings that she talked about and look at those health standards. So as a sister, it also scares, because you, at 24, looking at all of the past stuff that's going to happen and what the future could hold, you want to make sure that we can stave that off as much as possible. And also, like Dr. Chicoine had said, a lot of those situations that we talk about and we see, we want to make sure that my brother has those opportunities and we can be as proactive in his healthcare as much as possible. A lot of the difficulties, again, that we have is finding providers like Diane has mentioned that are willing to serve someone and provide medical care to someone with Down syndrome. A lot of providers aren't taking new patients lately after the COVID-19 piece. And then really understanding Down syndrome in its entirety has been difficult. Those providers that do, we had a great one who was out of Hasbro in Rhode Island, passed. And then you have a lot of newer people and a lot of, I think, pressure through COVID with providers to take on a lot more than they're actually able to. Zach has done really well with a lot of transitions through COVID. And like Diane has talked about, it was a shock to be home and not have his radio station and his friends and his community connections as much as he was staying home. With Down syndrome, obviously he has more susceptibility with his diagnoses to those diseases. This has been a great symposium to be a part of and to be asked to join, because it is definitely informational, and it was definitely great to meet everyone here and be a part of this process. Thank you.
Thank you very much, Ashley. So the next person that Sorry, I'm moving my papers around and I was answering a question in the chat. The next person is Daniel.
All right, so just bear with me as I get the slides up.
No problem.
All right, you guys see the slides?
Yes.
Yes, we.
Very good. So again, thank you guys so much for having me here as a panelist today. My name again is Dan Beam. I'm a regional long-term care ombudsman with the state of Connecticut with the long-term care ombudsman program under the Department of Aging and Disability Services. And I just wanted to quickly kind of review at a high level, bird's eye view, some of the services that the Department of Aging and Disability Services offers to individuals, and then talk about to piggyback on some of the concepts that we've discussed previously, that continuity of care and connecting health systems to make sure that the highest quality of care and service are provided to our loved ones and individuals with Down syndrome as they work their way through the long-term care system. And so at the Aging Disability Services Department, the mission is maximizing opportunities for the independence and well-being of people with disabilities and older adults in Connecticut. What the department does generally is provide a wide range of services to individuals with disabilities and older adults so that they can get their highest level of self-independence, self-direction, self-reliance, and independent living. I kind of broke down, I have an informational flyer which I'll share. We can put it in the chat, and then also we can make the slides available after. But some of the services that we offer regarding employment services, services to support employers, job skill development, on-the-job training, employment counseling, benefit counseling, interviews and resume skills. And this could be prior to getting a job or looking at retirement, looking at how it may affect other entitlements such as Social Security, Medicaid, what the eligibility requirements are, and ways to keep them and be able to have gainful employment. Under educational services, we do support in college career skills and training, Braille instruction, education best practices, students who are blind or have low vision, schoolwork transition, services to infants and preschool children who are blind or visually impaired, and then independent living services, community inclusion services for individuals who are deafblind, daily living aids and instructions, independent travel training, Social Security disability application processing and eligibility determination, fall prevention, programs to improve self-management of chronic health conditions, driver training for individuals with disabilities. As far as accessibility services, assistive technology services, deaf and hard of hearing counseling services, sign language interpreter registry, as well as the telecommunications relay services grant. Under advocacy, we do resident rights in long-term care facilities as the ombudsman, healthcare insurance counseling, disability rights advocacy, LGBT advocacy for older adults and long-term care residents, Medicare fraud prevention, and elder rights advocacy. And that's kind of like a bird's eye view, high-level summary of what the Aging and Disability Services Department offers. If you have any additional questions or want to look into any of these programs, I've got the contact information here, as well as the contact information for us at the Long-Term Care Ombudsman Program. Specifically looking, and I've also got the links to the flyers, specifically looking at the Long-Term Care Ombudsman Program and services that we offer individuals when they do enter the long-term care continuum. I guess I'll give you a quick history of the program as it was developed. There was a proportional increase of individuals receiving nursing home level of care, for the first half of the 1900s. But really with the implementation of Medicare in the 60s and then following with Medicaid, we saw a tremendous explosion of the nursing home industry. So just some statistics that I had pulled up. In 1939, there were 25,000 nursing home beds in the country. In 1960, there were 330,000 nursing home beds. By 1980, there was 1.5 million nursing home beds in the country, and by 2000, 2.8 million nursing home beds for individuals. And so there was a large growth of the industry. But up until the 70s, there really wasn't much regulation or oversight to it. And that's where we saw in the 60s and early 70s, there was concerns, multiple papers published about the poor conditions, substandard care, abuse and neglect that were happening in institutions. And that kind of started the ball rolling with the history of the Ombudsman program as you see it here. It started as a pilot program in the early 70s and then solidified under the Older Americans Act in 78. Since then, there's been several iterations of the strengthening and bolstering of our program, including that it was required that we change the name from the nursing home ombudsman to long-term care. We now also service individuals in assisted living or residential care homes, as well as our final regulations being published in the Federal Register in 2015. So here in Connecticut, we're a centralized model. So we are an independent organization within the state of the Department of Aging and Disability Services. There are 8 regional ombudsmen and 3 intake staff that cover the regions. I personally am in the South Central region of Connecticut. And so, you know, what we do, ombudsman, what does it mean? So it is an Old Norse word that directly translates to kind of advocate, and that's what we do. We advocate for residents of nursing homes, boarding care homes, or assisted living facilities to work to resolve problems based on problems that individuals face at this local, state, or national levels to ensure quality of life and quality of care. And this is, I think, what's so important as we piggyback on the previous presenters is making sure that the individual's rights, no matter what setting they're in, are upheld and that they are receiving that personalized care and tips and tricks. And as an advocate, want to make sure you're educated to your rights and work with you to advocate on your behalf. So what do? We investigate complaints, provide information about long-term care services, provide technical supports for family or residential care or family councils, advocate based on quality of life, quality of care. We are 100% private and confidential, so we don't discuss any concerns or issues raised without the explicit permission of the individual or their legal representative. And yeah, we seek legal, administrative, and other remedies to ensure resident rights are protected. You know, collaborating with multiple different agencies depending on the particular issue that may come up. What I do think is important to note is that I'm a long-term care ombudsman. I'm not the formal licensing or regulatory agency over long-term care facilities. That would be the Department of Public Health. I'm not a formal fact finder. My goal as an advocate is to ensure that resolution is found based on the resident and family desires. And so if there are particular issues that were to come up, whether it be related to your discharge rights or your rights to receive individualized care in the facility or the quality of care or your practitioners, you can raise issues to me, and then I'm more than happy to provide education and consult and investigate or advocate on your behalf based on your directions. And so just a quick summary of some of the basic resident rights that are outlined in federal regulations and state law: the right to citizenship, the right to dignity, the right to privacy, the right to have personal property, the right to get information. And so I think that's a big one, to be informed by your care team, to be part of that interdisciplinary care team, the right to care, to equal care, and also to have that individualized care provided. And that, you know, it's important that we can come to the table and help providers understand what a person's personalized care needs are, so that we can best ensure that those needs are met in the long-term care facility, whether it be for a short-term rehab stay. As Diane had mentioned, she had gone through a challenge where her loved one was in a short-term rehab facility, but wasn't quite getting the care and services that she wanted. So that's the type of situation where certainly you can always feel free to reach out to our office, and we're happy to assist. And you know, just to not beat a dead horse, because I know we're limited on time, but Dr. Chicoine, I can't emphasize enough and appreciate what you were saying as far as the health passport. Having that information, because to try to come to a table when you're in crisis and get all that information to your, whether it be the hospital team or the long-term care facility or short-term care facility, it's very challenging. And so to have a health passport filled out early and often, working with your providers, getting those specifics written down, the individual might not be able to express themselves in the future. But if we're planning ahead, you may be able to get some good insight documented now from them directly so that you can ensure to be a voice for somebody in the future if they do develop some cognitive limitations and are unable to be that voice in the future. And so you can always feel free to reach out to our office if there's any questions or concerns related to that process, and we're more than happy to help with you. I've got some resources that I've also put on the slides as far as individualized care planning in long-term care facilities, tips and tricks to advocate for your loved one or for yourself, and our contact information as well. And so again, great to be part of the panel, great to work with all you guys, and happy to answer any questions that may come in. Thank you.
Thank you so much, Daniel. That was a lot of information and we appreciate that. Thank you so much. So I'm going to pass it off to Dr. Pixie Plummer.
Hey, thank you so much for having me. I am an outpatient internal medicine provider with Starling Physicians in Bloomfield, Connecticut, and as was mentioned, I'm new to Connecticut in the past year. But I can't think of a more exciting way for your grant and your program to kick things off by having Dr. Chicoine speak. Your keynote is so vital, and you're a big hero to me. So I can't tell you how many copies of mental wellness for adults with Down syndrome I've handed out over the years. I might be one of your biggest purchasers on Amazon or otherwise, but thank you for all of your work. I think maybe what's important to just identify here today is that sometimes a provider like me, someone who may have a passion or special training in working with people with Down syndrome or other developmental disabilities, can establish a presence either within a health system or a community. And that provider at times can end up being kind of the go-to person. Word of mouth can spread, and you can feel that people are calling and requesting help from that provider. And any one provider can find themselves sometimes overwhelmed or unable to meet the needs for everyone. And so one of the things I'm interested in exploring and partnering on is how can we build capacity and in some ways integrate and infiltrate within existing health systems, but explore whatever way that people in Connecticut feel could be most helpful. I'll just say that I personally made sure to reserve part of my clinical time in such a way that it's flexible and open to supporting whatever effort might come out of this project, whether something as all-encompassing as the Down syndrome clinic that Dr. Chicoine has built, or a crisis response team is created. The story that you shared, Diane, with your sister is one that's very familiar to me, where no matter what transitions we've gone through, whether it's from peds to adult care, or from one supported living environment to the other, or a major health crisis, sometimes it's a family member or even or one social worker who identifies that what's happening as far as healthcare, something's not going right and someone's not listening. And I need to find someone who really understands to hear my story and help me in the middle of this crisis. And so if I could be a part of whatever grows out of this and contribute to that call for help and build up any program to support the people in Connecticut, I just wanted to say that I'm here ready for action. I would just like to echo, I love hearing about the sharing of pictures. And I know that I've seen over and over that, you know, when a patient is sick and at their most vulnerable, and to maybe a doctor who doesn't understand that just because you have Down syndrome or intellectual disability, that you are not sort of naturally progressing toward a loss of function, that one picture is really worth 1,000 words. And I've seen in the course of rounding, like a team is rounding on a patient who they're talking about, well, maybe it's time we should just move toward comfort care. I've seen the power of one photo, and it might have actually been a smile that occurred in the hospital the night before, taken on the parent's cell phone, change their outlook and realize that, by the way, they're waiting till you're out of the room to reveal their smile. And so they're not ready to like, let's keep going with the fight. So I just echo, use your cell phone at any time and keep those pictures handy to paint the picture of a life, a full life. So look forward to the questions and discussion.
I have to second that. The pictures speak 1,000 words, and for those folks that may be staff bringing someone to an appointment, maybe not the family member that may not be able to carry pictures around in a phone, a small photo book that they can take with them, showing that person doing things they are capable of, to be able to represent that person in a positive light to the healthcare folks, is a really important thing to be able to do. And it doesn't take a lot to be able to do that. So that's another take, you know, for someone to be able to do it. But I think having the pictures of the person being able to do things or in a very positive light is just so important. And I'm sorry, Diane, I'm taking up some of your time. So I'm going to pass it off. Last but not least, Diane, do you have anything else to share about your sister, or you want me to go to questions? Okay.
I just wanted to mention the Adler Center because some questions are coming in about that rather than addressing that separately. So at Yale, there is a place called the Dorothy Adler Geriatric Center. And if I can find the number, I'll put it on top. I think they have a waiting list right now, but they are just doing a very basic, so my sister started 10 years ago going, and then she'd gone sort of every year since and was steady. And then when this event happened, it reversed. Then the progress was slow, but he was great. Dr. Karen's there because he said, eliminate every other possible thing that you can, you know, UTIs, anxiety, depression, sleep apnea, this hydrocephalus, you know, he's like, go through that whole process. It's gonna be really hard, but then you'll get, you know, MRIs and CAT scans and things, and that way you'll have a better sense of things, because it's one of those diagnoses that, or a diagnosis that is the process of elimination oftentimes to get to dementia. There's not really a lot that can show on scans or tests to prove it. So that's all that I wanted to add, and I'll try to look up the number and put it in the chat for everyone. Thank you.
Thank you, Diane. So now we're going to go to questions, and I think that question is a good segue, Diane. I think as far as diagnosis, Dr. Chicoine, when in your presentation, I hope my screen changed. I hope I didn't lose Dr. Chicoine. In your presentation, you did talk about the diagnostic process and that most people before the age of 40. I was wondering if you could just talk a little bit more about that, because a lot of times folks, when they're assessed through their annual assessment, whether it's at DDS or at their private provider or whatever, there may be a change in their functioning, and their primary care doctor may diagnose, especially the person, if they have Down syndrome, may diagnose them early. Even when I worked at DDS, I even saw a diagnosis at 26 years old that the primary doctor said the person needed a group home, they had Down syndrome, and they didn't. It was actually, it turned out the young lady had severe depression because a sibling had left home and she had lost all her social contact because the siblings' friends weren't coming over, and just that natural relationship of socialization had all gone because the sibling had gone to college. So if you could talk a little bit more about that diagnostic process.
Yeah, that's real important. There's a concept called overshadowing where, because we know that people with Down syndrome have a higher rate of Alzheimer's disease, that any decline gets diagnosed as Alzheimer's disease, even without a good assessment for something else. So you really do want to look, as was mentioned, it really, in a sense, is a process of elimination. You want to look for the pattern of decline that's consistent with Alzheimer's disease. And then you want to look for other things that can cause dementia. Just as a clarification, dementia is sort of an overriding term, and Alzheimer's disease is one of the types of dementia, but there's lots of reasons for people to get dementia. Many of them, unfortunately, Alzheimer's disease in 2022 is not reversible at this point, but many of the causes for dementia are reversible. And so you really particularly want to look for those. And it may be that the person has Alzheimer's disease plus one of those other things. And again, we may not be able to fix Alzheimer's disease per se, but we can address those other things which may help the person function better longer. So really, it's very important to look for that pattern and then look for other things that can cause that before making the diagnosis.
Thank you. Thank you. And I've read that there's, and you had mentioned the genetic connection between the chromosome that causes the trisomy 1 and the Alzheimer's or dementia. Are you aware, like, is there research that it's ongoing, or if people are interested in looking at additional information, is that something that is being thoroughly studied, or is it just something that is being looked at on as they address Alzheimer's and dementia?
No, there's a lot of studies going on right now with regards to Alzheimer's and Down syndrome, looking at potential causes, looking at improving our diagnostic ability to diagnose Alzheimer's disease. I mean, certainly from ultimately a drug trial standpoint, having more objective evidence on making the diagnosis of Alzheimer's disease is going to be real critical. I've diagnosed Alzheimer's disease many times clinically. But a drug company is not likely to spend $100 million because Brian Chicoine said so, or yes or no. I mean, they're going to want something more objective than that. And so that's a good part of what's being done. And so lots of things going on. A lot of people are very interested in Alzheimer's disease and Down syndrome, not only to serve people with Down syndrome, but what are the implications that it may have for the rest of us as well, what we learn from people with Down syndrome and Alzheimer's. So lots and lots of stuff going on right now that LuMind or Global, if you look on their websites, they have lots of information on research.
Okay, thank you. Can you say those again for people?
Yeah, LuMind is LuMind, and then IDSC. It was two organizations that merged together. LuMind IDSC is one place, and then the Global Down Syndrome Foundation out of Denver is another place that you can see lots of information. And we have some information on our website about research as well, but those two would be probably the two primary ones I would look at.
Thank you. That's wonderful. I have tons of questions from your presentation, but I have to get to everybody on the panel. But I do, one of the other things that, I think a bunch of the panelists are qualified to talk about this, is talking about the preventative healthcare. And I think the preventative healthcare, DDS has put out the guidelines. They've done a really good job defining all the things that need to happen, right? But we have a doctor like Dr. Pixie Plummer. We have folks out there, but when it really comes to the vet, and you have the parents and the guardians and the individual primary care doctors, and we look at the research. And I just did a presentation that was funded by the CDC with Special Olympics regarding accessible healthcare and the statistics of people with disabilities for preventative healthcare. It's not good, right? They're not getting the preventative healthcare that they need to get, even with all the regulations or whatever guidelines the DDS put. So if you could talk about that, and then I'm going to hand off to Val and Dr. Plummer to talk about it as well.
Yeah, I think that's real important. So I was part of a group that helped develop the global healthcare guidelines for people with Down syndrome. I encourage people to take a look at that, and you can find that either on their site or ours, those guidelines. And that's the first step. There's still other topics we haven't addressed. So there are some screening things that are that should be the same as everyone else, and there are some screening things that we should do more of in people with Down syndrome based on their associated health conditions, and some things probably make sense to do less of based on association. For example, solid tumors are less common, so that's going to be part of the next round of the guidelines. And there are some of the screening things that are recommended for the rest of us should we not be doing for people with Down syndrome because they're so uncommon and have potential for complications. So those I think those are real important things to look at as we go forward. Is one I didn't focus on that, but I think certainly the issues in the office, not only the health screening, but immunizations, so important for a population that has impaired immunity to make sure that we're getting good immunization rates in the people with Down syndrome. And just for example, we have a very highly vaccinated practice for COVID in our practice, and the rates of COVID have dropped precipitously. We had 2020 was a very challenging year in our practice for COVID, and we see much less of that now. So just attention to those details and making sure that people are getting the preventative care that's so important.
Okay.
And just a comment, we had an article published this year on we called ableism at the bedside. We can make lots of rules, but really providers have got to do it at the bedside, and that's one of the challenges and that's where really family advocacy becomes so important. Advocacy by the family.
Right. I'm going to pass off to you, Val, on that question. I know sometimes it's not always the medical provider. Sometimes it's sometimes older parents who are like, no, they don't need to have that exam, or they don't need to have that. So how are you guys addressing it? How's DDS addressing that at this time?
DDS advocates for families and healthcare providers to address the same level of preventive care as they do and for anyone else. And you are correct, sometimes it is a family, especially when it comes to screenings for mammograms or different types of cancers like colon cancers. We do have to stress to families that just because people are in situations where they're not exposed or they haven't been involved in certain activities, that they are still at risk and they should have these screenings. And we encourage nurses statewide to be advocating for that with the individuals, primary care providers, as well as other specialists.
Okay. And Dr. Plummer, from your perspective, how have you been addressing this?
One thing I guess I would add is a lot of families and individuals express that achieving some of those screenings can come down to a few moments of accessibility or challenge, and that is not always just about physical accessibility, but also what does it feel like to have to go get my labs drawn, and does my office provide a comfortable way for me to check my weight and my blood pressure that's not overwhelming. So sometimes there are ways that if you know that this is the standard of care, but you can tell that the way care is delivered doesn't match your needs or your loved one's needs. It is sometimes also thinking ahead about, if I'm going to achieve that blood screening test, I need to know the right phlebotomist who has the right approach and schedule it on that day, or I'm going to plan to do it when I'm sedated for my dental procedure. So it does take some creativity and teamwork, and I know everyone here has experienced that, but just know you're not alone if you can't just cookie cutter check all of the screening boxes without some help.
But I also think it's an important part that the physician has to be aware of that and has to be part of that and part of that plan and understanding it so that they can coordinate it. So another question for you, Dr. Chicoine. After hearing our panelists today and what some of the things that we have going on in Connecticut, what's your immediate reaction to what we have available in Connecticut? And do you have any advice as far as pulling other folks to the table. We do have other aging and disability activities going on in Connecticut that some of the folks here on the panel are involved in, not specific to Down syndrome, but other aging and disability
Yeah, I mean,
activities.
it's clear you got lots of advocacy services and lots of services, informational services trying to provide. I mean, you shouldn't have Dr. Plummer, but it wasn't clear to me just and Dr. Valencia Bagby Young. It wasn't clear to me how how well the state is covered with physicians and whatnot or other healthcare providers. That wasn't clear to me. But I would offer that there was a study came out this past year that only about 5% of adults with Down syndrome have access to a clinic for adults with Down syndrome, and 95% don't. And many of them are getting wonderful care by physicians like Dr. Plummer and Dr. Valencia Bagby Young, but many people don't have access to that, so there's still a struggle. And so I would encourage, one of the things I would encourage would be to look at referring your provider to the Down syndrome medical interest group, which I'm part of. And there's lots of good information for providers. We've developed a webinar series whose main audience focus is primary care providers to try to share information with them. And we're actually in the process of developing a process where providers could reach out via Zoom, if you will, and get support in treating an individual with Down syndrome. So many people with Down syndrome are going to be cared for in practices with 1 or 2 people with Down syndrome, and so their provider may not be as and so and that's really become a big part of my mission, if you will, and part of the mission of the Down syndrome medical interest group to support those providers. When we started the clinic, this is great, we'll have a clinic in every state of the union before long, and 30 some years have gone by, and there's still a handful of clinics for adults with Down syndrome, so it's, we're a long way from that. But in the meantime, we can really try to provide services. And so I think, with all the things that you've got in place to try to connect people with providers, I think that's probably the question I get asked most commonly from around the country is how do I find a provider in my area? So it was mentioned, find and provide, how to help provide providers. And I would certainly, if you can share that information with the people in your state, I think that's a huge, huge benefit.
Yeah, in Connecticut, we have Dr. Jerry Kearns, and he does do a specific clinic on a certain day. I'm not aware of specifically what day or when he does it, but I know folks are aware of that clinic that he does. But most people in Connecticut are getting their health care through their primary care doctor. They're not going to a clinic. But I think that is a great resource. The Down syndrome medical interest group, you said?
Correct.
Yeah. That's a great resource to be able to hand out to different physician groups. I think that because we do have a lot of large practice groups like Pro Health in Connecticut, Hartford Healthcare, some really large conglomerates that would be great information that maybe this committee, when we regroup, could put some information together and get out to those groups and provide them with that information. Thank you very much. So Ashley, from a sibling's point of view, as a family member, how have you guys been preparing for that?
Well, it's been a struggle only because my family decided to move from another state into Connecticut at the height of the pandemic. So for us, it's been a struggle to get into a lot of the pieces that even we're discussing now or that I deal with in my professional capacity because COVID threw a wrench into everything. We shut down a lot. We weren't doing a lot. We weren't submitting anything in paper. Everything had to be virtual. And that was a really hard process. And we're still battling that process, including physicians and probate, because you needed Connecticut physicians to go through probate. And like I said, a lot of physicians that we have experienced in where my family lives, it's close to the Rhode Island border, that aren't accepting new patients and aren't accepting individuals that have Down syndrome as new patients. A lot of the questions that and comments that we get are that, we can't take him on because he has Down syndrome, or we're not prepared for someone with Down syndrome, and that's what we've hit, and that has been very difficult to move forward. Again, because I have that background with Dr. Val and all of those trainings that we've had to deal with regards to Down syndrome and their aging and their future, it's really making sure that we're prepared as much as possible. And for my brother, I think that's keeping him as engaged as I know Diane said, as engaged as much as possible with people that are not just family. So the radio station has become a very big part of him. Especially because he's with natural supports. And I think the natural supports that are not family are extremely crucial as these people age, to have varying degrees of relationships that are not just the people we see on a daily basis. With Diane, I had the pleasure of coaching Christine. So I was able to give another perspective of what I was able to see that helped her through some of the process, I hope. Because I could see, and I was a different realm, it is very clear that, like Dr. Plummer said, that they tend to show different sides of themselves when other people are experiencing them, or in the room or not in the room. And so I think that really the relationship piece in keeping Zach is engaged mentally, physically, which goes back to Dr. Chicoine's presentation, is extremely important for Zach.
I think that's absolutely correct. And I have a couple of more questions for you. As your role as a provider, in what ways can you assist, do you assist people that you serve here in Connecticut?
So we're very similar to Daniel. We also help with a lot of the advocacy pieces, and again, ensuring that they're as independent and engaged within their community as much as possible, and that can be within their day services, so their employment, or to be out into their community, as well as in residential, so whether they live in their own home or apartment with their family, or live in a residential facility or home with other individuals that have developmental disabilities or intellectual disabilities. I think that it really, as far as the aging piece, this has been the biggest struggle, especially with a lot of providers. I've definitely dealt with a lot of medical providers that have done what Dr. Val had talked about, which is, it's definitely easy to write them off because of their disability or what's going on around them, rather than what might be the core cause of it. I definitely have seen firsthand what Dr. Val was talking about with regards to the wanting to not do the preventative care. And I've lost quite a few participants because they've refused or won't, or the families wouldn't. And then all of a sudden we're at a situation where we're at an aggressive breast cancer, if you will. And all of a sudden it's, wait a minute, what just happened? And, if some of that preventative care had been put in place or talked about a little bit more to be creative, would we have had a different outcome? So really from that aspect, it's helping them as much as possible to advocate. We're with them more so than other providers could be. So being able to show our perspective, especially when there's a change in condition, is important.
Thank you very much. That's really, really important point. Talking a little bit about your Special Olympics coaching, can you talk from that perspective across the lifespan, how important just being involved in those activities, and some of the inclusiveness and the healthy athlete part of that too, that they're able to participate in?
So
people know about that.
Yes. So Special Olympics has definitely been an organization that I've been really proud to be a part of for the last 15 plus years, in various capacities. I'm the swim instructor, and with regards to that and all that you see, it's amazing to see how much they can progress. And it's not just the physical aspect, although the exercise that comes with some of the different sports is important, as Dr. Chicoine said in his presentation. Exercise is very important, especially after COVID. COVID hit Special Olympics really hard, to not be involved in those. But again, it really kind of comes back to that social aspect too as well. because they have such a social network, especially when you get to the bigger games, the regional events, the state games where everyone's there. And to see their faces light up and to really be a part of something is extremely important to them. That's also at their skill level, so it doesn't matter, you know. I think the biggest piece that really kind of came out in the last few years that you're talking about is they've always done the Healthy Athletes Village during state games, where they've had different providers. They've had eye doctors come and provide exams. They've had the dental come, because dental is definitely one of the harder parts with our population, Down syndrome, as well as just all with intellectual and developmental disabilities. But the Fit 5 was the biggest piece that kind of came out in the last few years, which is a program that's designed for all of Special Olympics to really talk about healthy eating and exercise and all the aspects that go into a healthy lifestyle. And that's been really important for the individuals and the athletes to be a part of, as well as us coaches, because it really does go back to Dr. Chicoine's presentation of all of those aspects to reducing stress, and exercise and healthy eating will attribute to our longevity in the long run.
And I think the other part is the inclusive activities, the sports, is getting folks involved at a very young age and doing the inclusive activity as well. Dan, a question for you. How do you see everybody here, how do you see you collaborating with DDS and in what you do in your work?
Yeah, absolutely. So I think it's about the continuity of care is big, and we talk about routines. We talk about individuals who have an issue that might, end up in a different system or a transition from one setting to another. I think it could be very helpful if individuals did ever have challenges related to that transition, where they were in a supportive housing situation prior and maybe had a change of status, an acute health episode happens and they ended up, hospitalized and then entering into the long or short-term care settings. If there were challenges related to that, or challenges related to them returning back to their home of origin, that's certainly something that I'm more than happy to collaborate with the community partners to ensure that the individual's needs and desires are known, whether it be incoming to the nursing facility or returning back to the community, to make sure that there is that smooth continuity of care and that their individualized needs are met. That'd be a great opportunity to collaborate.
Thank you, Dan. Thank you so much. So I'm trying to get everybody in here in the last 10 minutes before we wrap up. Dr. Pixie Plummer, so have you experienced roadblocks in Connecticut trying to get families connected with services, or what is your experience then?
Well, as you know, I'm new, so I have a lot to learn. I do think one thing that's come up right away was questions about mental health supports, and who in Connecticut knows about working with people with developmental disabilities, Down syndrome and otherwise, in the manner that your team, Dr. Chicoine, you have the OT, who's also a PhD in disability studies, and the licensed clinical social worker. I think questions about how to integrate mental health supports keeps coming up, and I don't have answers. So be interested in what anybody has to offer.
Okay, so I'm going to pass it off to Dr. Val there.
So in terms of mental health, we refer to a variety of community services. We start with 211. We have licensed psychologists in every DDS region, and they have a list of community providers, and they refer individuals and families. They don't share that list, because when we have a really good provider and we share the list, they get overwhelmed and then they are no longer able to provide that service. But if people reach out to them in the regions, they provide that service. DDS also has a helpline that people can call, and they can refer somebody to a support person in the region. So that's how we provide resources for mental health support, as well as primary care and other specialists that have experience with persons with Down syndrome and tend to be more patient and understanding.
So also the overarching question, there's so much that DDS does, right? You have so many resources, you've talked about the dental, you've talked about the different health policies and guidelines, the trainings that you do. How do people, other than you're here today telling us, and we have, about 100 people on here today, but how are people, do they know the DDS is doing all of this?
A lot of times they may not know unless they come in direct contact with us. So if it's a family member, we do have the DDS website. There is a section for individuals and families, and there's also a section with DDS health standards and preventative care guidelines and delegated tasks. That that website is accessible to anyone, so they can go on that. We also speak at DDS developmental associations and different groups. We share, I've gone to meetings and shared information. So, and DDS case managers are also available. Hospitals and other community providers are aware of DDS and some of the services that we provide, and they will often call us or reach out to somebody and connect in that way. We do try to be involved in outreach as much as possible. With the pandemic that doesn't seem to be wanting to end yet, it's been very challenging for us and individuals and families.
Yeah.
But we are still.
So one of the questions I got, and then I have another question for Dr. Chicoine. One of the questions that I got, Val, was some of the trainings that you mentioned, are they available to folks who are not in the group homes? So are any of the trainings that you have, the available Down syndrome trainings, available to other folks?
Some of the trainings
on the website.
Most of the trainings are geared to direct caregivers, but we do provide individualized trainings. Like if a family has a question or concern, either the dental coordinator or myself or another nurse manager can meet with them and try to help meet that need. We have provided presentations that have been open to anyone. If it's related to medical concerns, we will usually invite nurses first, and then it's open to case managers, parents, or other individuals that may want to attend. So we do make that information and resources available. And when we provide certain health standards or memos that are geared to staff or nursing, we also try to provide the same thing for families and individuals, so that the language different terminology may be used, but we provide the same information.
Okay. So Dr. Chicoine, the question that I got was, does Connecticut or does any state need a physical clinic, or with the use of technology, could we just have a virtual clinic? So.
Yeah, that's a great question. I mean, I think one thing I would advocate politically would be that we look at reciprocity of licenses, because I have a license in Illinois at the moment, and my license, I cannot see people virtually in Connecticut because my license does not cover Connecticut. So I can drive my car through Indiana, and my driver's license still covers Indiana, but my medical license does not. So I think that would be the first thing I would encourage. I don't know that we'll ever have a national license because there's too much money in it for the states to have control the licenses, but I think reciprocity would be one thing. So I think the ultimate answer to that question is I would hope so. Perhaps not exactly a direct. What we're trying to develop with the Down Syndrome Medical Interest Group would allow providers to reach out to this expert panel and share cases and get support in caring for their individuals with Down syndrome. So I mean, that's a first step, just because of the license issues that what you're describing with regards to virtual clinics is not available. I know Harvard does some of that, or in Mass General, I should say, does some of that with people with Down syndrome, but I don't know what their coverage range is. I would imagine they would cover Connecticut, which is close, but I don't know that for a fact.
Okay. Okay. Thank you.
I would ask, there was also a question about training. I would also, if people are looking at the NTG, the National Task Group on Intellectual Disabilities and Dementia, has some great training programs. I would encourage you that if you just Google NTG, Intellectual Disabilities, or NTG Dementia, you will find their website. It's a very nice, they have a lot of good information. They're the ones who did that question, the questionnaire on dementia that I showed.
Okay. Okay. So I'm going to pass it back to you, Shannon.
Okay, thank you. Well, we have had just lots and lots of information. This has been wonderful. I want to thank all of our panelists and Dr. Chicoine for joining us. You know, to go back to Diane's story at the beginning, where she was asking for help for Christine, and then kind of things didn't happen, and then you know, her sister declined as a result of things not happening when they needed to. That story is not, she is not alone in that story. When people call me, invariably between family, the state, and medical providers, someone in that triad has said they just won't let them go. When I go back and talk to people, that phrase comes up consistently, and we really need to do better. So I am hoping that this is the beginning of changing that, of turning that around. So there is never anyone in that triad who says they just won't let go. Lots of food for thought here. Thank you to everyone. Thank you to the Connecticut Council on Developmental Disabilities for supporting us, our steering committee members who have been meeting and providing us information all year long as we develop this program, our participants, and you know, all the people who've helped make this possible. We are grateful to you all, and I hope you'll join us. This is we see this as only the beginning, the very first step in a process of making things good for our people who live with Down syndrome. So thank you, everyone.
Thank you.
Thank
I
you.
just want to add, can everyone just put in the panelists, their contact information before you sign off to the chat? Thank you so much.
Okay. And thank you, Shannon and Diane. Thank you, everyone, for attending today's webinar, a virtual symposium, Down syndrome, aging, and health. If you have any other questions, please reach out to Shannon McCormick. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete that, provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of the Down Syndrome Association of Connecticut and our presenters, thank you for joining us today, and have a great rest of your day.